Hey everyone, I'm Katie Werner. I'm the Community Outreach and Marketing Director at Team Phenomenal Hope. Welcome tonight to our final educational webinar for PH Awareness Month, Current PH Research and Evolving Therapies. So tonight's speakers are Dr. John Kingrey of INTEGRIS Baptist Medical Center, Dr. Sue Gu of UC Health, and nurse practitioner Elise Whalen of Texas Children's Hospital. So before we get started, I just want to share a quick thank you to our sponsors for supporting all of our events for Awareness Month. One small reminder that at the end of this webinar, we will have an opportunity for Q&A. You'll just need to put your questions into the chat and we'll go through those questions that way. So with that, I'll go ahead and kick us off. Dr. Kingrey, it's all yours.
Good evening, everyone. My name is John Kingrey. I am a pulmonary critical care physician here in Oklahoma City, Oklahoma, and excited to share some what I think is actually really exciting news and exciting developments in the world of pulmonary arterial hypertension or group 1 pulmonary hypertension. I take care of a whole big group of patients with PAH and other forms of pulmonary hypertension as well. And my team and I pretty much focus on that. So we are really excited about what's going to be available to our patients. And my purpose here is to kind of just give you some highlights of what's going on in the world of pulmonary hypertension and specifically in PAH or group 1 disease. So I think that one of the things that you all may or may not know, but in all of our bodies, there's a battle going on. And there's forces of good and forces of evil, if you will, that are trying to maintain balance in the tiny little pulmonary arteries. And really all the blood vessels throughout your body, but especially in the pulmonary arteries. There are forces that try to keep things where they're at, and there are forces that try to help make those pulmonary arteries worse. And what you need to remember is that you have hundreds of thousands of these little guys. And this is the problem in PAH, is that, as you can see, they're in between the angel and the devil there is that you get remodeling. So that pink part where blood should be going through gets significantly more narrowed with time. And to date, in the world of pulmonary arterial hypertension, the only thing that we've really been able to do is just dilate that blood vessel that's already been remodeled. And what I'm going to present here this evening is just are some newer therapies that are on the horizon that may be able to change where we've been kind of stuck for 25 years, which is just dilating that blood vessel. So I don't want to get you bogged down in the science, but you should be aware that in healthy pulmonary arteries, you have functioning protein called BMPR2. Scientists like to name those proteins that it stands for something larger, but just keep that in mind when you're looking at some of these diagrams. And then you may be familiar with a substance called serotonin, because serotonin is largely made in your gut, but it not only impacts gut health, but brain health and other things. And that's something that is bad for pulmonary arteries when you have too much serotonin, okay? So I'm just going to be referencing these in the few studies or medications that are kind of on the horizon. So again, this is kind of another way of looking at it. And remember, we're talking about arteries that are microscopic. So we're blowing them up here so you can see. But current therapy has us impacting 3 different pathways. Some of you with PAH may be on 3 different pulmonary hypertension drugs, and that's because we are attacking all 3 of these pathways to try to help dilate those blood vessels, okay? But all of this muscle in here, it gets damaged, okay, in PAH. And again, that blood vessel gets thicker. And there's all sorts of complicated things happening on the surface of these blood vessels that tell them to either get bigger, proliferate, or to kind of stay where they're at. All right. And we don't want them. The problem with this disease is that those cells have been told to kind of go crazy. In a small kind of way, kind of like cancer, when cancer cells get out of control, they go crazy and they grow. And that's kind of what's happening in PAH. It's not cancer, but there are some similarities there. Okay. So I mentioned just a minute ago that serotonin can cause damage to the blood vessels. Okay. And when you're looking at impacting serotonin as a possible target, this has been looked at for many, many years, actually. And but I'm highlighting a therapy that is on the horizon. It's called redatrostat. Okay, and it's in a phase 2 trial, which phase 2 trials exist to demonstrate safety and effectiveness on a small scale. And that's what's happening right now at certain places in the country. And to participate in this trial, you have to have PAH. You have to be greater than 18, age greater than 18. And then there are certain studies that you kind of have to fit in the parameters with 6-minute walk and lung function tests. And you also have to be currently treated with medication for PAH. But my point in showing you these slides is not to get bogged down in all these big words, but just to kind of understand what's happening. This drug is getting in the way of an enzyme that actually helps to produce serotonin. So if we can block that enzyme, then less serotonin gets produced. And so this is one drug that's out there right now in clinical trial that, depending on your center, not every center in the country is participating in all clinical trials, but it is something that's out there, and at least on a small scale, is showing some very good progress. So there's also a drug called seralutinib. Okay, and again, I don't want you to get bogged down in all of these diagrams, but suffice it to say that there are some bad actors, some evil humors, if you will, that cause inflammation and proliferation, or that kind of expansion of those cells in your pulmonary arteries that cause them to get bigger and cause them to narrow the area through which blood can flow. And so this is a drug that's an inhaler, actually, and all these little red marks, it's getting in the way, okay, of ultimately you have people with PAH have signals that are activating bad proteins here, these like PDGF proteins, which then in turn turn down BMPR2, which, remember, that's a good protein that is healthy when and should be operating normally. But in patients with PAH, that protein is not acting healthily. And so this drug is going to get in the way of certain molecules or certain proteins that actually turn that down even more. So if we can block that, then you're going to be able to preserve some of those healthy BMPR2 shown in this purple, okay, so that they can function and do their job and stay away from the proliferation and the inflammation. Okay. So this is kind of a cool little thing. You can kind of see it in real life. This is on a mouse, but this right here with all these kind of purple dots, that's a damaged pulmonary artery. Okay. And what this drug was shown to do is taking a damaged pulmonary artery and actually walking that back. So we're not just dilating here, we're actually kind of undoing, if you will, some of that damage, which is really, really exciting that we have medications or drugs that are being investigated that have the potential to not just dilate the blood vessel, because that doesn't really change the disease a whole lot, but to actually walk back some of the inflammation. It's a really exciting horizon in PAH. Okay. Now, this is in a phase 2. This just finished a phase 2 trial. Okay. And it's anticipated that a phase 3 trial is going to be launched next year. Okay. And so a phase 3 trial is one that demonstrates effectiveness on a large scale, and it must show benefit for the FDA to approve it. Okay. So the preliminary results seem to be encouraging. We don't have all of that announced yet, although we anticipate it soon. And if things look good, then you might be able to participate in a phase 3 trial if you have PAH. Okay. And again, this is an inhaler. So we've talked about one thing that's a pill. This is an inhaler. And then lastly, there's a medication called sotatercept. And this, again, I'm showing you the science here just so that you can kind of understand some cool things that are going on. And you have this scale, right? That's kind of this tug of war that I mentioned earlier. And what happens in PAH, this model on the left, is again, this BMPR2, which is healthy, it's getting shut down, okay? And it leads to this bad balance where all of these proteins over here that cause proliferation and cause that blood vessel to get thicker are winning, and it's just getting out of control. And what this drug does, sotatercept, is it comes over here on kind of the enemy side, okay, and starts to bind these evil humors over here, if you will, so that is not tipping the scales in the favor of creating more inflammation and more proliferation, which is again increasing the number of cells, which is bad. Okay. So this drug's going to kind of restore the balance. That was the thought. And there actually have been phase 2 and phase 3 trials that are completed, and the results have really been amazing. Among other things, this drug was shown to improve the resistance to blood flow in your lungs. That in turn causes the heart to be able to work better, and it helped people feel significantly better, walk further, and so on. So of the 3 drugs that I showed you, this one's kind of the farthest along in the process of becoming approved. And with those exciting phase 3 results, some of you listening may have participated in this trial. There is a lot of hope and a lot of expectation that this drug is going to be coming to the market pretty soon. Okay. And so we anticipate this is going to be the next new PAH compound to hit the market. And this will really be the first new compound or different type of molecule of a drug that's come to the pulmonary hypertension space in well over 5-7 years. Okay. And really, this is going to be the first drug, assume it hits the market first, that's going to be a drug that kind of can help walk back some of that proliferation, some of that bad damage that's helped or that's caused the arteries to get narrowed and small. And so the word undo is probably not completely fair, but what it is showing is that we can modify the disease somewhat. And instead of just dilating, we're going to change the disease. Okay. And this is something that could be approved. We don't know this yet, but it could be approved as soon as 2024. This is an injection that you give yourself one shot every 3 weeks. Okay. So it's not like a continuous pump. It's just a single injection every 3 weeks. Okay. And lastly, I show this only so that you can see how much activity is going on in the world of PAH and a whole bunch of different targets for drugs. And this actually doesn't even show all of them, but it helps you understand that scientists are really actively involved in looking for ways to the next step to making PAH a curable disease. Thank you so much for listening. I look forward to hearing from our colleagues, and hopefully some of these drugs we talk about are going to be available to you in the coming few years.
My name is Sue Gu. I'm a pulmonary critical care doctor at University of Colorado, and I treat pulmonary hypertension patients. But most of my job is actually doing research and giving pulmonary hypertension to animals like mice and rats. So some of those pictures that John just showed, that's kind of most of my job is to use animal models of pulmonary hypertension so that hopefully I can be on one of the producing ends of the pipelines for future therapies. So we heard from a lot of you that we wanted to hear about what are the new emerging therapies for the other types of pulmonary hypertension. For many years, we've made a lot of great advances for group 1 pulmonary arterial hypertension, or PAH. And what we've heard for a long time is just that there aren't any FDA approved therapies for any of the other groups of pulmonary hypertension, but there have been some really promising emerging therapies, especially in group 3 PH. And I want to share some of those things with all of you so that if you have pulmonary hypertension associated with one of the other groups, you can feel excited and reassured that there are great things and great studies happening in all these other types of PH as well. One other thing I wanted to share is to equip you all with this great tool that is run by the government, and it's free. Any clinical trials that happened in the United States and internationally all get registered at this clinicaltrials.gov website. So you can actually search for the condition of pulmonary hypertension, and then you can put in dates of the study. So I just put in kind of a recent date of 2019 as an example. And as John already mentioned, there are these phases that are required by the FDA for approval of drugs. So as he said, phase 2 trials are ones that assess the safety and the side effects of medications. And a phase 3 trial is one that shows whether a medicine is actually efficacious in treating a certain condition. And then phase 4 is more longer term, kind of longer side effects of a medication. So you can search and apply these filters and actually go through yourself and see what studies are recruiting. And you can look up on the website the details of the studies and the sites where they're actually recruiting from, so that if you're curious about what studies you're eligible for, you might even be able to find one that's not offered in your geographic location and find out about things available across the country. So this is a main tool that I use just to make sure that I covered all the bases for all the studies that are actively recruiting and all the types of pulmonary hypertension that we're going to talk about. So without further ado, I'll jump into group 2 pulmonary hypertension, which is due to left-sided heart disease. So in this space, it's been really exciting because in the past couple of years, there have been this explosion of trials in what's called SGLT2 inhibitors, which are sodium glucose cotransporter 2 inhibitors. These were originally used for diabetes because these are receptors that are in the kidneys that transport sodium and glucose across the kidneys, and they were being prescribed to diabetic patients and also patients with heart failure with reduced ejection fraction. But we know that a very common cause of pulmonary hypertension is heart failure with preserved ejection fraction. And that was one of the types of heart failure that for many years has not had any FDA approved treatments. So these inhibitors were the first class of drugs that have actually been shown to benefit patients with HFpEF, or heart failure with preserved ejection fraction. And they include these names that are hard to pronounce, like sotagliflozin, empagliflozin, dapagliflozin, and canagliflozin. And many of these trials, here's just a table that you can reference if you're going back through these slides later on, that shows all of these trials that have come out in the last couple of years that have shown that many of these drugs have reduced the combined risk of cardiovascular death or hospitalization for heart failure. So even though these aren't specifically for pulmonary hypertension due to HFpEF, for our large HFpEF community, this is a really great thing. And so if you have PH due to HFpEF, the underlying treatment is just treating the underlying disease. So these are new options that are now available. And then John also set us up really well for this, which is that since sotatercept was shown to be so efficacious in treating group 1 PAH, we're now seeing how does it help with the remodeling or reversing the changes that happen in the pulmonary vessels of pulmonary hypertension due to other types of pulmonary hypertension. So this is a study that's phase 2 actively recruiting for sotatercept for the treatment of combined pulmonary hypertension due to pre and post capillary pulmonary hypertension. So to qualify for this study, you have to have a diagnosis of HFpEF, or heart failure with preserved ejection fraction. And then you have to have the right heart cath demonstrating that you have not only pulmonary hypertension, but that you also have an increased pulmonary capillary wedge pressure and an elevated pulmonary vascular resistance. So that's elements of both left-sided heart disease, which is this elevated pulmonary capillary wedge pressure, and elements of the pre-capillary pulmonary hypertension, which is this elevated pulmonary vascular resistance. So this is really great news because for a long time, most patients that had an elevated pulmonary capillary wedge pressure were excluded from trials of PAH drugs. And now this is, now we're studying sotatercept and seeing whether it's going to be beneficial in those patients. And then another exciting pathway that is being explored in different forms of pulmonary hypertension has to do with the metabolic syndrome and metabolism. So one of these trials is metformin, which is another drug that has been used for a long time for diabetes. And this is now a phase 2 trial recruiting for metformin for pulmonary hypertension due to heart failure with preserved ejection fraction. So in order to qualify for this study, you have to have pulmonary hypertension due to heart failure with preserved ejection fraction. You have to meet the criteria by right heart catheterization, and also 3 or more features of metabolic syndrome, like being overweight or having high cholesterol or having diabetes. So this tries to get at that other pathway of just overall metabolism and processing of sugar, and metformin is kind of targeting that. And now moving on to group 3 pulmonary hypertension due to lung disease. For many years, it was feared that the oral drugs that were available for pulmonary arterial hypertension, when they're given to patients with lung disease, and they have, just going back to the slide again, they have all these abnormalities in the lungs themselves, opening up the pulmonary vessels to all these damaged areas of the lung was actually going to be non-beneficial or even harmful, because it would decrease the overall oxygen, because it's allowing the areas of the lungs that don't get good oxygen to get increased blood flow. So overall would have a negative effect. So the way that researchers have thought to address this is actually to give inhaled drug, so that the drug is only getting to the areas of the lung that are getting good ventilation. So because you're not taking the drug orally, it's not going to get to the parts of the lungs that are already very damaged or fibrotic. They're only going to get to the parts where the airways are nice and open and the drug can reach those airways. So inhaled treprostinil, as many of you might know, was approved in the past for PAH, which is group 1 PH, and also pulmonary hypertension associated with interstitial lung disease. So this trial was about 5 years ago, and was a randomized controlled trial of inhaled Tyvaso. And the way that this drug is delivered is it's given by a nebulized device, and it's in chunks of 3 breaths per session. So a patient has to sit there with a nebulizer, do 3 breaths, and then they have to repeat that 4 times daily, spaced out at 4-hour intervals, because the drug would wear off. And then they would go up by 3 breaths. So a dose would be 3 breaths or 6 breaths, up to 9 or 12 breaths per session. So some patients would be doing 9 or 12 breaths per session, 4 times daily. So the exciting thing is, over this last year, the FDA just approved dry powder inhaler formulation of inhaled treprostinil or Tyvaso. And this is really nice because you only have to do 1 breath per cartridge, and that 1 breath, breathing in that medicine, that reaches the lungs in the same way as 3 breaths would have with that big nebulized device. And you also don't have to prep the device or fill it with water or do anything. You just have to literally load a little cartridge that's already available in a number of different strengths. And each dose inhaled takes less than 2 seconds. So this really simplifies the delivery of the drug for our patients with group 3 pulmonary hypertension. And again, this is available for patients with PH due to interstitial lung disease. Now, what we don't know yet is whether this drug, the inhaled treprostinil or Tyvaso, is going to be beneficial in patients with pulmonary hypertension due to COPD, which is another huge cohort of our patients that have pulmonary hypertension. That's group 3. So they just completed enrolling and getting patients into this phase 3 trial. So we're no longer actively recruiting, but we don't know the results of this study yet. But there were 76 sites across the US and internationally where patients were able to be enrolled if they had a diagnosis of PH due to COPD and had the clinical diagnosis of COPD made using their pulmonary function tests. So they were looking at whether there was a change in their exercise capacity or their 6-minute walk distance after 12 weeks of getting the inhaled treprostinil. So we should be seeing the results of this study soon. And if it was positive, then that might be a new treatment available for our PH due to COPD patients. And then another cohort of patients that it's another small rare disease population is sarcoidosis. So sarcoidosis is a disease that causes scarring in the lungs as well as enlarged lymph nodes and involvement of other organs. So this is a study that is looking at whether inhaled treprostinil can also help those patients with pulmonary hypertension due to sarcoidosis. And then another option that might make things even easier for our group 3 pulmonary hypertension patients is this treprostinil palmitil inhalation powder, which is actually only once a day. So this is a phase 2 trial that's actively recruiting at 33 sites, and they're going to treat patients over 16 weeks. So this will be pulmonary hypertension due to interstitial lung disease, and this might open up more options for delivery systems for inhaled treprostinil. Another exciting potential inhaled delivery drug system is pulsed inhaled nitric oxide in patients with pulmonary fibrosis. So in patients that already are wearing oxygen by nasal cannula, there's a device that's actually going to be able to give inhaled nitric oxide gas, which is a gas that some of you that have undergone a right heart cath might have actually already received this one time in the cath lab. And usually it's tied to an expensive machine that's only available in the hospital or in the cath lab, but this is a device that delivers this gas by means of a pulse device and through a nasal cannula. So patients with pulmonary hypertension due to these types of interstitial pneumonias or interstitial lung disease could be eligible to be enrolled in this study. And then lastly, one more thing coming through the pipeline for pulmonary hypertension with COPD, a phase 2 trial that's not yet recruiting. So we don't know what sites are going to be available for this study yet, but this is going to be another inhaled dry powder medicine. But this compound is a soluble guanylyl cyclase stimulator. And so this is another pathway of drugs that has not been available to patients with pulmonary hypertension due to lung disease or to COPD because it's only been available in oral form. But this is now going to be an inhaled form that we're going to see whether there's going to be any benefit in the exercise capacity or 6-minute walk distance in patients with pulmonary hypertension due to COPD. And last but not least, I know we've already had a webinar that some of you might have attended on group 4 pulmonary hypertension or CTEPH. So CTEPH is a curable disease for those that are able to undergo surgery and have removal of the blood clots that are blocking up the pulmonary arteries. But many patients might have disease in the more distal arteries that are too small to be accessed by surgery, or for other reasons like comorbidities or other things are just not healthy enough or unable to undergo surgery to remove the blood clots. So for those patients that have what we deem inoperable CTEPH. The two alternative options have been an oral pill called riociguat and a more an invasive procedure, but less invasive than surgery, the balloon pulmonary angioplasty. So there have been a number of studies that have looked at these two therapies that have been already commonly used for inoperable CTEPH that have examined just how effective these two therapies are. So the good news is that meta-analyses, which is basically aggregates a bunch of different clinical studies, have shown that both of these methods improve the exercise capacity or the 6-minute walk distance and hemodynamics in patients with inoperable CTEPH. So this is great. This just confirms that what we've been doing for our inoperable CTEPH patients, that there is benefit. And then some other studies have looked at whether the combination of the two might together improve prognosis. So there's been one big single center series of 138 patients that have shown that they have really good survival rates of 100% down to 90% at years 1, 2, 3, and 5 after the diagnosis, using a combination of the riociguat plus the balloon pulmonary angioplasty. And then some other studies have compared head-to-head riociguat versus balloon pulmonary angioplasty and have shown that balloon pulmonary angioplasty, if you can get to a center that does this and does it well, it actually does lower the PA pressures and the pulmonary vascular resistance more compared to the oral medication, the riociguat, but it does have some higher complication rates, which obviously would come about because you're doing a more invasive procedure as opposed to taking a pill without a procedure. So these are the findings of the recent studies on these two interventions. And then one more trial that I want to make our patients aware of is that we are studying macitentan, which is another drug that is available for pulmonary arterial hypertension. And now we're looking at it in our inoperable or our persistent or recurrent chronic thromboembolic pulmonary hypertension patients. So at 33 locations throughout the US, patients will be eligible if they have CTEPH that's either inoperable due to the location of their blood clots, or they have persistent or recurrent CTEPH even after doing balloon pulmonary angioplasty or the surgery, which is the pulmonary endarterectomy. So again, I just wanted to arm you all with the data so that you can reference all those trials either by reviewing the slides in this webinar again, or by going directly to clinicaltrials.gov, and you can see all the studies that are actively recruiting or are going to be recruiting soon. And again, there is a lot of hope and a lot of movement and positive directions in all of our different types of pulmonary hypertension, not just the group 1 PAH.
My name's Elise Whalen. I am a nurse practitioner at Texas Children's Hospital in Houston, and I take care of kids who have pulmonary hypertension. So kind of to go over a little bit, I do want to focus on pediatric research, but many of the care standards, a lot of the medications we use are all based on adult clinical trials. And I felt like our presenters before me presented all of the great things in the pipeline. And I kind of wanted to go into just some considerations that we take from the pediatric side as from the adult side. So the first thing is pediatric pH is not pH in little adults. We do use the similar hemodynamic criteria, meaning whenever we get our cardiac caths done, we follow the same guidelines. And that was really intended to kind of speak the same language. And so our kids, whenever we get caths, they have to go under general anesthesia. It's much riskier than potentially a sedated cath or something like that many adults get. But some of the key differences are in the classification, which I'll open up, causes and symptoms, diagnosis, and treatment. So on this slide, we know we have our WHO groups, but on the pediatric realm, we kind of took it and said, okay, well, there are the WHO groups, but there's this additional classification called the Panama classification. And we kind of outlined here all of the other reasons why a kid who can have pulmonary hypertension, which I know is a little bit different than adults. So we see a lot more patients with idiopathic pH, genetic pH. Genetics is huge for us in pediatrics, and congenital heart disease. So much different. And so, like I said, I outlined all of these. And so if as an adult patient, a lot of the things that we see in kids is that the kids who have genetic reasons for PH, their parents had it. And I feel like we see it a lot, where the child might not be screened, even though their adult caregiver or related person has PH, until the child starts having symptoms. So if you know that you have a genetic link and you have children, since we have the audience, you ask about it, see about screening your kids or other members in your family, because that could be pretty important. So in kids, there's actually, of all of these therapies listed here, you probably recognize many of them. There's only one that's FDA approved, which is kind of crazy. And that was approved in 2017 for patients who are 3 years and up. And so we take care of kids, as you saw on the previous slide, who have chronic lung conditions. So they might be born prematurely. They might be born at 26 weeks, or they have all kinds of reasons. And we use these medications based on really pediatric experience, and then we also look at the adult clinical trials, which, as you might expect, they're not apples to apples. And so it makes it challenging in terms of understanding how these medications work, understanding appropriate dosages for these, and kind of what we can expect from a side effect perspective. So we use many of the same, we follow the same pathways. We use many of the same medications, but the way we use them might be just a little bit different. So some of the main things that we look at, and they're a little bit different than adults, is making sure that these kids are vaccinated. That's a big one in pediatrics. We think about respiratory tract infections. So, these kids, especially those in daycare or in schools, they are exposed to many more viruses than, somebody who can maybe isolate themselves a little bit better. And then just some of the same things that you all might experience as adults is, making sure that you're addressing lung disease, aiming for happy lungs, all of those things. We also look at growth and development, which is kind of a little bit of a shift. And so making sure that they're developing appropriately, growing well, constipation, we always think about, we don't want these kids straining, and activity. So with kids, which is one of my favorite things about kids, is I get to watch them grow up. I strive to focus on their quality of life, so that way they can do things like go to prom or graduate high school, or maybe something as simple as just going to school. Sometimes it's just trying to understand what their goals are. And so the other thing with this age is teenagers and wanting to be competitive and trying to beat out the next person. And so there's a lot of just different things to think about for this group. And the other thing is just they don't want other kids to know that they're different. And so that's another thing that we're kind of looking at as well. So we try to focus, on the quality of life and kind of the patient and family experience for this. So just some things to think about as you learn about the adult clinical trials that are there. What are some of the challenges that we have down the pipeline? So for us, we only have 8 accredited PH centers. In Houston, the next accredited center for us, the closest one is in Nashville and Vanderbilt. So for us, we get patients from all over the country, and many centers aren't experienced with taking care of these patients, which I know is a larger problem, but there's just not a lot of people who know about PH, especially in kids. I don't think I mentioned this, but the incidence of PH in children based on registry data is 5 to 8 cases per year, with about 26 to 33 children total per million affected. So I compared it to the adult data. It's quite a bit less. And so people don't think about PH in kids a lot. It's the zebra disease, right? And so, people just don't know about it. High cost burden, which I think we all can appreciate with prior authorizations, the cost of these medications, but you add that plus the challenge of it not being FDA approved and getting insurances to believe that you want to use this medication that really isn't recommended to be used in children. And then this kind of goes into the next one, which is limited pharmacotherapy data. We just don't have a lot of experience, which, there's a lot of opportunity for research and to learn more about these things, which I'll go into. But for right now, to take care of these patients, it's hard. So there's some adequacy concerns, and I know we didn't talk about this yet. One of the big things that kind of rocked our world in the last several months was the unveiling of the Remunity pump. And so for us, and the pediatric PH world is very small. We all know each other, and we know, like I have NP colleagues across the country and in Canada. And when we heard about the Remunity pump, our message was that all of our patients who are on sub-Q Remodulin, they weren't going to be able to get new pumps. And the pump is only approved, FDA approved for patients 22 years and up, which is fine. That's one thing, but we can't get this pump approved. And because the former pump, which is it's a smaller pump, it looks a little bit different. They don't make a part of it anymore. And so we don't even really have a backup plan. So just a lot of issues with this pump. We all came together and wrote letters, and we teamed up to try to help these patients. And the other concerning thing is a lot of dosing limitations. So we could have a baby, there's something else to think about, who weighs 8 kilograms, which is pretty small. And because of the way this pump is configured, the lowest rate that it can go is it's pretty much starting out a baby on about, and we do our dosing 34, so it'd be 34 nanograms per kilogram per minute, which is just way too high for a baby. And these things I don't think are thought about sometimes. I think pediatric pH is sometimes the second thought, but when it comes to making big decisions for pH, you have to think about the kids, because the Remunity pump, I think, is the best example of that. It's really been a challenge for our patients and for our healthcare teams to navigate that. And so the other thing is just a stress for ongoing research funding. Like I said, these medications are only approved. One of them, there's only one that's approved, and there's a lot of opportunity and a lot of potential for ongoing research. And I think that just that highlights that. So I kind of followed Dr. Gu's her presentation on the clinicaltrials.gov, and I had looked up all of the active studies for pediatric PH in the last 5 years, active and then completed studies on my next slide. And so there are several, and like I said, these are studies that not every center is involved in for pediatric PH. Some of these are international studies. So Japan, I think there was one in China. Saudi Arabia might have been another one, which is interesting because these medications might not always be available in every country. And so it is interesting to think about where different countries are also in PH research. So some of these are one of the active studies, which we're working on at our center, is a study looking at just starting out a patient on a single therapy and adding on a dual therapy and looking at clinical endpoints for that. Thinking about inflammatory biomarkers. I think one of the bigger studies that we've had is looking at physical activity and the use of actigraphies like Fitbits and things like that to measure 6-minute walk test distance in a way that matches someone who can't walk. Because we have a lot of babies who have PH, but they can't walk. We can get 6-minute walk tests on them. Thinking about different growth markers, TGF-beta, microRNA, things like that. And then we also, the actigraphy study was the Fitbit study that I just talked about. And then looking at macitentan in Japan. Completed studies, like I said, it was basically two. It was for older kids and younger kids. They were looking at actigraphy, iloprost, looking at a lot of congenital heart disease. So patients who have one heart ventricle, and looking at Remodulin for those patients, which is kind of interesting. Looking at, sickle cell patients, tadalafil, a study using the Future 3 study, looking at bosentan and frequency of dosing. So, these are just kind of some studies that we've completed, some studies that we're working on. Though I think the world of pediatric PH is very exciting. I think that, like I said, we learn a lot from the adult side, but we also have, just because of the developmental reasons that patients can have PH, and there's just a lot of unique factors that I think opens the door to research. So with that, I will stop sharing, and I think we're opening it up for questions.
I have a question for Elise. for our for dealing with pediatric patients that might have a limited life expectancy, or just, will have will not be able to live a completely normal life. Do you guys get counselors involved early on, or therapists, or anyone to kind of help with that psychological aspect?
That's a great question. And I guess I should have we're working on a multi-center study. I'm one of the PIs on it, looking at anxiety and depression. COVID-19, I think, spiked anxiety, depression in children. I think the rates have increased pretty substantially. And there's not a lot of understanding of the effects of chronic disease like PH in kids. There's very little published studies on it. And so we're looking at that. We work with the schools pretty closely. We try to get palliative care involved, and palliative care often has a psychologist that's paired with them. Our goal is actually to get palliative care involved early, just because of the number of teams, specialists, factors who might be involved. But yes, we work with their schools. We work with their school nurses. We're now evaluating for anxiety and depression in our clinics, which I know not every site does, but we're hoping to kind of set a standard for that. So lots of things. It's hard. I mean, I think there's so many factors to think about. So.
Well, I don't think we have any more questions at this time.
I got a question from Abby. I don't know if Abby, you wanted me to just answer in the general audience, or if this was a question from the audience, but Abby sent me a question that, can patients enroll in clinical trials anywhere? So I think that, one of the tricky things is they require regular follow-ups often in these clinical trials. So you would have to kind of be located near the center that is enrolling for the trial. And I think that patients would just have to be either referred or self-referred to that PH center. So they would just be seen there and bring, whatever records that they have, so that you might not have to repeat everything at that center. But I think if your center is not doing a particular trial and you find that it's available somewhere else, the considerations would just be getting there, getting all of your records there, and being able to get seen, and then to follow up on a regular basis as required by that trial.
Yeah, and I would just add too that most trials are going to pay for transportation costs. If you live several hours away, or even not that far, they'll at least try to help you cover the cost of transportation, which doesn't do anything for your time necessarily, but these trials are really hard to recruit, to get patients to come to. So if you have interest, and you find a place that's not in your backyard, but something where you might be able to go to, they definitely help out with those costs.
Yeah, thank you, Sue and John. I do get asked very frequently from patients, how can I enroll in clinical trials or find out about clinical trials? And you guys nicely pointed out that the clinicaltrials.gov is really the best resource. And just to add on to what John just said, I don't know of any company that doesn't pay for patients to travel, even to fly to other centers to participate in clinical research studies if they're interested in that. So there is a lot of assistance if you, receive care somewhere that doesn't participate in clinical trials or has limited clinical trials. Just investigate it and see what the options are for you.
We had a question. Why are adult congenital patients excluded from trials?
Actually, a lot of the PAH trials, they're not excluded. Most of the adult congenital things we see in PAH, the predominance is atrial septal defects, but many trials do accept patients with adult congenital heart disease patients. So
just wanted to say thank you to everyone for attending this evening, and thank you to our presenters for taking the time to help us out and speak with us tonight. And one final thank you to our sponsors for helping to make this happen. Also want to share that all of our recordings for webinars from this month will be accessible on our website. So take a look. You can access any of this information at your leisure. Thanks again, everyone. Hope you have a great week, and hope to see you again soon.